In emergency medicine, there's no room for guesswork. When a life is on the line, when chaos is all around you, the only thing that brings clarity is protocol. Today, we're diving into that protocol for life, step by critical step.
Okay, let's throw you right into the deep end. Picture this, you're doing chest compressions, your heart is pounding, a colleague rushes in to take over. You need to switch. How much time do you have? Every second feels like an eternity, and the clock is ticking.
Less than 5 seconds. That's it. Any longer, and the blood flow to the brain and heart just tanks. This is why a universal, memorized algorithm isn't just a nice idea, it is absolutely, fundamentally essential for survival.
So, let's break down that universal algorithm. This is the blueprint for action that every rescuer, from a bystander to a doctor, follows, starting from the very first moment. It all kicks off with a simple acronym, DRSABCD. First up, D for danger, you have to make sure the scene is safe for you. Then R for response, a shake and a shout. Nothing? S, send for help immediately. Now we get to the life-saving stuff. A for airway, get it open. B for breathing, are they? If not, we move to C for CPR, and D for defibrillation. It's a cascade, one step logically following the next.
And when you start CPR, it's not just pushing on a chest, it's a science with very specific numbers. You're aiming for a rate of 100 to 120 compressions a minute. Yep, that's the beat of staying alive. You need to go deep, 5 to 6 centimeters on an adult, and that ratio is golden. 30 compressions, then 2 breaths. All while keeping any pauses, like we said, under 5 seconds.
But CPR is just buying time. We need to fix the underlying problem, and that often comes down to the heart's electrical rhythm. Broadly speaking, you've got 2 categories. On one side, shockable rhythms, where the heart's electricity is just haywire. The defibrillator can basically act like a hard reboot. But on the other side, you've got non-shockable rhythms, like a flatline, where there's no electrical chaos to reset. A shock there would do absolutely nothing.
And this is exactly what we're talking about. This is ventricular fibrillation, or VF. See that? It's not a heartbeat. It's pure electrical chaos. The heart is just quivering, totally unable to pump a single drop of blood. This is the exact situation where a powerful jolt of electricity can wipe the slate clean and hopefully let the heart's own natural pacemaker take back control.
So what happens when Plan A doesn't work? You've shocked the patient 3 times, you're doing great CPR, but that chaotic rhythm is still on the monitor. Where does the algorithm tell you to go next? Well, now we bring in the pharmacy.
The protocol is crystal clear. After that 3rd shock, you give drugs. It's a 1-2 punch. 1 milligram of adrenaline to help get the heart going, and 300 milligrams of amiodarone, an antiarrhythmic to try and stabilize that rhythm. And of course, you never, ever stop that high-quality CPR.
Okay, so we've been focused on when the heart itself is the primary problem. But now, let's pivot. What happens when the heart is just a victim, caught in the crossfire of a massive, body-wide crisis?
Here we go, a totally different scenario. A 5-year-old girl, a bee sting, and now she's in full-blown anaphylactic shock. Her blood pressure is terrifyingly low. We know the treatment is adrenaline, but the dose is everything. So, for a child this age, what's the correct intramuscular dose?
And the answer is 150 micrograms. This is so important. It shows that even with the same drug, the context is critical. You can't just guess. For kids, dosing is precise, based on their age and size to make sure it works and doesn't cause harm.
And this table puts it all into perspective. You can see it clearly. An adult gets 500 micrograms. For a kid between 6 and 12, it drops to 300. And for our little patient between 6 months and 6 years, it's 150. This isn't a suggestion, it's a carefully worked out protocol. All right, let's shift gears again. We're moving from an electrical problem and an allergic reaction to, well, a plumbing problem. A catastrophic plumbing problem. Massive blood loss from trauma.
So, in this situation, the absolute priority is stopping the bleeding and replacing the fluid that's been lost. But to do that effectively, we need to know how bad it is. How do we classify it? What percentage of blood loss puts someone in the most severe category of shock?
The number is just chilling. Losing more than 40% of your body's total blood volume. That's class 4 shock. We're talking about a state of profound crisis, where the entire circulatory system is right on the edge of complete collapse. Now this chart is so revealing.
It shows how the body fights to survive as it loses blood. But here's the really crucial takeaway. Look at the blood pressure. It stays pretty much normal in the first two classes. Why? Because your body is compensating like crazy, clamping down vessels to keep that pressure up. The scary part is, by the time the blood pressure finally drops, you are already deep in the class 3 shock. You're way behind the curve, and treatment has to escalate fast, from just fluids to a massive blood transfusion.
Okay, for our final section, we're going to look at situations where the environment itself changes everything. I mean, it literally forces you to throw out parts of the standard rulebook, because extreme conditions require a completely different approach.
Take this case. A man is in cardiac arrest, but he's also profoundly hypothermic. His core temperature is only 26 degrees Celsius. That's incredibly cold. Now, the monitor shows PEA, electrical activity, but no pulse. The standard algorithm says to give adrenaline right away. But does that rule still apply when a patient is frozen?
And the answer is a hard no. This is the key. In a severely cold patient, the rules are completely flipped on their head. That cold heart just doesn't respond to drugs in the same way. In fact, giving the standard doses can actually cause them to build up to toxic levels.
So the hypothermia protocol shifts the entire focus. You actually withhold adrenaline until the body warms up to at least 30 degrees. You even pause giving shocks. The number one priority is no longer drugs or electricity. It's one thing and one thing only: aggressively rewarm the patient. You have to treat the cold before you can effectively treat the arrest.
And that really gets to the heart of it, doesn't it? Resuscitation is this incredible dance between following a rigid, evidence-based protocol and having the wisdom and judgment to know when you need to adapt it for the unique human being in front of you. The protocol provides the path, but expertise knows when to change course.
And this leaves us with a final, lingering thought. These protocols are amazing, built on decades of data and experience, but they're always a reflection of the past. So what happens when we face a crisis that's completely new? How will these life-saving rules continue to evolve? And what does that mean for the future of emergency medicine?